So let's take a look at Emergent module or shock. This is kind of a review for my students, but it's a great review for all students. So let's get started. What is the drug of choice for cardiogenic shock? It's nitrates, nitroglycerin, or nipride. We want to be able to vasodilate, open the vessels, so the heart will not work as hard. So when you learn about heart attacks, you learn MONA, morphine, oxygen, nitrates, and aspirin. I know that it's changing and evolving as we're going forward, but as a basic beginning nurse, it's great to understand that nitrates will vasodilate to decrease the workload of the heart. So we really want that to happen. We want to always, if we're giving nitrates, we want to always monitor our blood pressure. It is so important. So if you start a nitro drip or nipride drip, please, if you're going to vasodilate, it's going to bring the blood pressure down very quickly. So make sure that you're monitoring a blood pressure cuff is on your patient and you are taking blood pressures regularly, usually Q15 if they're on a drip, just an FYI. What is one shock that you are not tachycardic? Neurogenic shock. It's the only shock we are not tachy. We are bradycardic with neurogenic shock. So if you get a patient and they've had, say, a head injury, a neck injury, a fall, something, and they are shocky, you can see all these things happening, but they're bradycardic, you need to think neurogenic shock. So what is the problem in cardiogenic shock? I want you just to remember, this is not an electrical problem. This is a pump problem. So it's the pump or mechanical part of the heart that has caused cardiogenic shock. It's the muscle. If I use epinephrine for anaphylactic shock, what drug is used for neurogenic shock? Vasopressors. There are a lot of different vasopressors out there. We'll talk about them in the lecture, but just know if you're asked, what am I going to give for neurogenic shock? It's going to be a vasopressor. Why? And we'll talk about it here in another slide, but we want to squeeze the vessels, right? And that's what pressors do. They press or squeeze the vessel, and that's what our goal is. So we learned about burns, and we know that we can go into hypovolemic shock very easily with burns, especially depending on where and how much the body is burned. So remember our Parkland formula. It's 4 milliliters times the body weight in kgs or kilograms times the percent of the burn. So you need the rule of nines to look at that. Look at where the burn is, get that percentage of burn per the rule of nines, but you're going to multiply 4 milliliters times the body weight in kilograms. If they're in pounds, we divide by 2.2 to get our kilograms times the percent of the burn. That's going to give you a big number. Then you're going to take that number and divide it in half, just 2 into it, half, this half and this half. Give the first half or 50% in 8 hours from the time of the burn. So if a person was burned at 12 o'clock noon, they come into the ER at 2, you've already lost 2 of your 8 hours. We go from the time of the injury. So 50% the first 8 hours, then you give the second 50% in 16 hours. Get this. 8 plus 16 is 24 hours. So we're going to give this big, large amount of fluids in 24 hours so that we can hopefully be ahead of the loss of fluids due to the plasma being able to leak through the capillaries and get behind that or on top of that so that we don't go into hypovolemic shock. So the Parkland formula is that it's 4 milliliters and it's lactated ringers is our fluid of choice, times the body weight in kgs, times the percent of burn, and that's per the rule of nines. Divide it in half, First half, we're going to give in the first 8 hours from the time of injury, and the second half in the next 16 hours, so that the entire amount of fluid is given in 24 hours. I hope that helps. So if my vessels tighten when I lose volume, what do my vessels do if I have a spinal cord injury? They lose tone and resistance, or resistance and tone. So if I have a spinal cord injury, it's going to interrupt that whole system of how I can squeeze down and maintain blood pressure. I lose resistance and tone. And if you think about this, if we go back a couple slides, what do we give? What is the drug of choice for spinal cord injury? Vasopressors. We need to press or help squeeze because we can't do it anymore. So we need to help with that increasing resistance and tone with a vasopressor. But that's what happens with spinal cord injuries. So they present a little differently, just kind of an FYI. So for my students, I taught this already in another unit, and I keep saying, you're going to see this on a test, and you are going to see it. And so I want to go over it. If we have mass casualties, clients will be triaged. Triaging is so important. And when you are triaging, what are we doing? We are actually prioritizing care and taking our sickest or the person or patient client that needs us immediately first. And then we go down in the system of actual critically thinking through who and what needs what. But out in the field, if you have a mass casualty, we need to triage quickly. And so just a reminder, the black tag is imminent death. It doesn't mean that they're actually dead at that moment, but there is nothing that can medically be done to help this person, and they're going to die within minutes. So that is imminent death. We can't save them. Red tag is life-threatening injuries and needs immediate attention. If it's red, I always think red, woo, 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 red, right? Red, danger, red, we need to go, red, let's go. It's a lot of stops. If you're in the mood flying through, it's a stop. They need help now. However you want to remember this, the red tag means life-threatening injuries and needs immediate attention. They need to be either put in an ambulance or a helicopter and sent to the hospital immediately. They need care. There's no bypassing them. You're going to put your hands on them. And then green or white tags, depending on your system, are walking and talking. They might have some minor injuries like abrasions or something, but nothing that needs care anytime soon. Really something that they could probably even take care of themselves. So walkie-talkies are good. And lots of times what we want to do is take that green and white person that's been tagged that if we need them and have them help or support others. It's an emotional time when you have mass casualties. It's an emotional time when things are happening. And so every hand that's capable on deck needs to be giving to the cause. So sometimes you can do that, just depending. One thing I do want to say, so let's look. Mass casualty incident triage. This just gives you a breakdown. It's an algorithm. I love algorithms. So if this is it, the arrow comes down. Is this the patient? Is the patient breathing? Yes or no? If no, we come down and we are black tagged. It comes on down and you can see red tagged. It looks kind of pinky. And then we have green and yellow. So it's just a great visual so that it just kind of brings it home for you. Don't get too caught up. For my students in review, it's pretty simple. If they're not breathing, what are they? If you need to do CPR immediately, if the patient is breathing, yes, and then stops, what are we going to do? You know, or whatever. Take a look through that. It's pretty simple. I don't want you to get bogged down in this because we have so much other stuff to cover. So, but I do want to just share this with you. I think it's a good thing. So when we have any kind of trauma, if we've got any patient that's coded, if we've gone through anything, it's stressful for us. So why do we need to debrief? There's many reasons, but it helps us with post-traumatic stress. We feel everything that happens. So one of the things, if you ever are in these situations, debriefing is a good thing. Sit down, talk it out. If you don't want to talk or you can't talk at the time, reach out to someone you can talk to. But the best thing to do is when the situation is over is to sit down and debrief it. This is what do you think? How do you feel? We can fix issues and problems and become more efficient in what we do. We can help ourselves with the mental aspect of the trauma that we've witnessed and had to work with. And if there has been death or a poor outcome, it's a time for us to be able to not pin it all up, but to let it out and share with our peers. It's a non-judgmental forum. So you should feel safe when you go to a debriefing. But it is to help with post-traumatic stress. So here's just a little reminder. What range should your arterial blood gas, a PaO2, be? Now, we do SaO2. Those are your oxygen saturations that we put on our finger and we measure up on the monitor. But we have a PaO2, and that is the blood oxygen. We get it from our arterial blood gas, our ABG, and it is the most accurate oxygenation number that we have. And what should it be? Just so you can remember, it's 88 to 100. Now, normally on our oxygen saturation, when we put it on our finger, we want to see above a 90, lots of times above a 92, right? So 90 or better with our SAT, but an 88 to 100 for our PaO2, just FYI. It is so important that you understand your isolation and prevent spreading of infection, diseases, or germs. I was just talking about this the other day about how we have people that go into the hospital and then get staph and different things. So not only is that an issue or situation, but also when we are dealing with really sick people, they can have really bad germs, and we don't want to share these with others. Excuse me. So it is so vitally important that you go through, review your isolations. We have standard precautions, airborne and droplet, contact, and reverse or neutropenic, depending on how you want to look at it or how your facility addresses it. Learn them and which one to use. It's always important to know. Remember, one of the things, TB is one thing we just learned recently, and tuberculosis is an airborne. It's in the air. That's why we put them in negative pressure rooms. COVID, we put them in that negative pressure room. We need to filter out what's happening because we inhale that and we actually will be exposed to the actual virus or whatever's happening. So we need to be very, very careful. So that's something for you to review. So a patient is hit with a sledgehammer to the left leg. He's holding his thigh and his hip, screaming and wallowing in pain. Ooh, it hurts. What shock would you or could you suspect? Hypovolemic shock. It's a large bone involvement, which are femurs, pelvic girdles. Those are your biggies. They can lose between 300 and 500 milliliters or cc's of blood when fractured. People can bleed to death from these large bone fractures. So it's so important that you understand that. Another thing I want to say, if you lose blood, we give blood. It is so important. Hang different volumes. We can do volume expanders. We can use LR normal saline while we're waiting for that blood to come, but it needs to be done emergently. Type and cross your patient for 2 to 4 units, depending on what the doctor wants, usually 2 units. And then go ahead, and sometimes we'll have to do uncrossed blood because it's emergent and we need to get it there. And we're ready to go, and we just pour it in. It's so important so that we prevent hypovolemic shock. And hey, for my students, And for anybody else, if you're taking NCLEX or anything, or you're looking, remember, or you're in an ER, you're in a clinic, if they've got a large bone fracture or a suspected one, think this way. They're losing blood quickly, and I need to do something. They can bleed to death internally before we ever can get them if we're not on it. So go ahead and just think about that. So what do you always check when there's a broken bone or a joint injury? I watch football. I love it. I'll watch it, and we see joint injuries all the time, basketball joint injuries all the time. We'll see broken bones and deformities while we're watching these sports. And so what do I always want to do if one of these folks are my patient or client? Let's see. I want to check a pulse. Pulse, check it. No pulse, no perfusion to the affected area. They will lose their limb. If they don't have a pulse, if they fracture the arm and there's no pulse, you can't feel a radial pulse, they can lose their arm. If they have a leg and you have no pedal pulse, they can lose part of their leg or their entire leg. The fracture is either severed the artery or the bone or something's compromising or pinching off that, so we're not getting blood flow. Lots of times what happens if we have an actual fracture or something, or a joint, something that's dislocated, that's compromising or pushing on a vessel that's preventing blood to get down to the extremity, if we rearrange it and pull it back into place. So we want to do that. You need to be trained to do that. You just don't jump on scene and go, I know what to do, and grab, and cause other trouble. But know this. Check a pulse. If you have none, it is a medical emergency. They're going to lose their limbs. So we want to make sure any broken bone or joint fracture. The other thing I want to say is you check for the pulse, hopefully have one, and then always check the unaffected side. If it's a right arm involvement, then check the left arm pulse. You want to compare pulses. Same with legs. Compare the pulses, because you might have a really weak, thready pulse on one side and a bounding pulse on the unaffected side. So we need to know that of what's going on. Or very faint pulse on the injured side and a normal pulse on the uninjured side. And because of that, we need to understand we're not getting great blood flow to that injured area. So something to remember. So we're back to our burns. Remember, as we look at first degree, second degree, and third degree burns, what do they look like? I have slides in my lecture where you have these people that are on their social media with their sunburns and all. If it's not blistered, it's just red, it involves just the epidermis, it's a first degree burn. Always remember what you do for burns. We stop the burning process. We run it under cool water, not ice or ice cold water, and we run it for 10 to 15 minutes to stop the burn. Get off of the old using butter and grease. I know, I'm from the South. Our grandmothers said, put a little butter on that, it'll be fine. What we're doing is just cooking the skin a little bit more. It's just like putting butter on the turkey or butter on whatever you're cooking, the pork chop. We don't need to do that. So those are first degree burns. We have second degree burns. Of course, you'll have pain, blisters. It can be splotchy. It can be different depths. So if it's a little higher up in the skin up there they can heal, but we need to be very careful, because the number one thing that kills burn patients is infection. That's our worry. Hypovolemic shock, if it's a large area of burn and the depth of it, and we lose a lot of volume, hypovolemic shock. But the number one cause of death is infection, because what is our skin? It is the largest organ, and it protects us from everything out there. We need it. So when it's compromised, it's open to anything to come and can create infection, and we don't want that. So it's so vitally important that we are very careful. Aseptic technique, sterile when needed, and take care of these patients. Also, if we're doing any kind of wound burn care, always to medicate them for pain. These are not patients that you decide you're not going to give a narcotic to because you're worried about addiction. They need the narcotic. This is very painful. It is usually debridement of skin, and even though a lot of it is dead skin, the tissue next to it or where you're going to can have nerve endings. So it can be very, very painful. And the process of changing that, you will start to granulate new tissue. And when you do, it can cause more pain because things are coming back to life as long as it hasn't been damaged beyond. And then we have third degree burns, of course, that white leathery. And then if we go down further, we're to the bone, charred. There is an actual a table that looks similar to this, but it is in the book, and that's the one I will use for my students for testing. But for this one, it's there. It's got all the information you need. Read through because you do need to understand burns. So who wants to run and hide? I shouldn't say that because actually the agency that's responsible for emergency plans and it accredits does the accreditation of hospitals is Joint Commission, and they're the ones that come and help are responsible for making these emergency plans for us. So it's a good thing. But when Joint Commission comes into the house and they announce it over, they're here, everybody kind of scatters. So don't be afraid. Do what you're supposed to do. Follow your hospital protocols or clinical protocols, and you will be fine with Joint Commission. But they're a good thing because they are the ones who are responsible for establishing emergency plans. So remember our emergency assessment. We are doing A, B, C, D, E, right? And so what are these? A is for airway. We want to make sure we have an open airway. That is different than breathing. So you can have an open airway but not be breathing, and that's where we need to breathe for you. But if we don't, say we choked on something, we don't have an open airway and it needs to be opened because no matter what, you're not going to get air down. They're not going to be able to breathe. So airway, breathing, circulation, right? So that's our pulse, our circulation. Are we perfusing? Are we circulating blood? Now, in CPR, I want to go back, and I think I have a slide on this coming, but we do it cab style now, is what I always say. So we do compressions first, then our airway, and then breathing, because the thought is that when a patient or person takes their last breath and then cardiac arrests or respiratory rest, they have that breath inside. So there is oxygenated blood, but they're not perfusing. They don't have a pulse. So what do? We compress fast and hard. We want to get it in there and circulate that oxygen, and then we go to airway and then give 2 breaths. We used to do it opposite. We do airway, you want to call for help. You need help to come, but we would do it and then look for the breaths, and then we would start compressions. We waited all that time, and that time was not wasted, but too long of a period of time that they have proven that it's better for us to compress first. So do your compressions first. Disability, that's the level of consciousness. What are they? Are they awake? Are they asleep? We need to know. So that's the LOC. Did they lose consciousness in an accident or whatever? We need to know that. And how long were they out? If someone has lost consciousness, they're passed out, or they've hurt their head, then what you need to do is it needs to be timed. Approximately how long? Were you out for 5 minutes? Can you tell? Lots of people can't, but if other people are around, normally witnesses can tell you, oh, they were down for a little while. They were down for at least a minute. They were down for 2 minutes, whatever. And then they came to, or they've been down for 5 minutes, so that we know. So disability or LOC. E is exposed. We need to cut those clothes off. We use those trauma shears. Students love it. Cut off the clothes because we want to look. You're exposing, you're doing a quick visual look down, pressing, touching, going down, and you need to turn them. If you need C-spine protection, make sure you have C-spine and log roll to the side. Take a look down the back, make sure there's no step off in the spinal cord, and you want to see, is there any injury? You might have an abdominal gunshot wound that enters in and you see all this yuck, and you're so tunnel visioned into that that you miss that he has 4 stab wounds in the back of the lung area, and that his lung is collapsed and will not breathe. And really, the lung probably will kill him. The stabbings will kill him before the gunshot wound. So it's so important that we expose and look. Then I want to say this, and make a note in your notes wherever you're taking. If you're doing this, if you're writing this out, you want to keep them warm. You don't cut everything off and leave them hanging out there. We need to keep them warm because they're going to work to stay warm. The body works even harder and shivers and stuff. It expends energy, and we have no energy to give if we're in a trauma situation or a code situation. So it's very, very important. And F, finish the semester. Yay! For a lot of you, for my students, it's graduation time. And for others of you, you might be finishing this one and getting to that last one. Whatever your situation is always finishing a semester successfully is a great thing. So a large truck with unknown chemical explodes on the highway and a bicycle race is in the area. Approximately 50 people are covered with this chemical. What should we do? This day and age, we need to think about it because you're going to probably either be involved in it or be at a facility where you're going to be asked to help out. So it's good to just to kind of think it through ahead of the game. So what should the hospital and nursing staff prepare to do first? We want to decontaminate them. You don't want people bringing chemicals into to contaminate other patients or people that are in the hospital. So we'll set up the decontamination, outside showers, take off clothes, all of that, contain that stuff. Then they come into the ER and be treated at that point. Take off clothes immediately, cleanse the skin with large amounts of soap and water. Chemicals need to come off the skin. They can burn, we can absorb whatever, and it can be detrimental to the person. So that's what we would do first. So a chemical disaster happens, what do you do? Now, for my students, I'm not necessarily going to test you on this. You might see it on your NCLEX, but I kept this in because with everything going on in the news, what we're seeing today, where there's a lot of war and different things happening, this is important to know for you and for your loved ones. So if a chemical disaster happens, what do? Close any open windows. And this time of year where I live, we open up all the windows. We have to close them. It gets cold at night, but we open them up during the day and air the houses out. Close those windows. Turn off all fans, heaters, and air conditioners. They will bring air and circulate. There's circulating air. We need to be very careful. We need to turn everything off. We don't want any outside air or ventilation to come in. Fans only stir things, so if something is coming in and you have a fan, it's just going to keep it going in the air. Turn it off. Close the fireplace damper. A lot of people where I live in my area have fireplaces, so you want to close the damper. We're closing the outside off, if you think about it. Windows are closed. Turn anything off that will bring air in and close that damper. Stay inside. It's not the time to go out looking around to see what's going on. Stay inside until you know it is safe, and they will let you know. People, the emergency folks out there will come and they will let you know. Don't go out trying to figure out, is it still safe, because you will become one of the victims or patients that will need to be treated. Keep the bad air out. That is the ticket. If you have a chemical disaster, keep the bad air out, good air in, and hopefully prevent yourself from being inhaling the chemical, which can cause chemical inhalant burns and other issues. We don't want it. Bad air out. So a tornado has been spotted and the hospital activates a code Toro. So it could be a code Toro, it could be a code whatever it is for your facility for when there is a tornado. What should the nurse do? You should make sure all guests remain in the hospital. This isn't the time to go having the guests go on, get out. You need to get out. There's a bad storm coming. No. Code Toro has been called, or Code Tornado, over the intercom system. All guests are to stay. You need to go ahead and get them secured, and do not leave the facility. It's so important, because if not, they could walk out right into it, and we don't need that. We need to keep them safe. Make sure you close the blinds or curtains in the rooms, because that will protect if the glass blows in, the windows blow in, or anything else. It can help protect that from entering into the room, and protect them from flying debris. So we want to make sure none of that happens. So after an intense event, emotional shock can take place in those involved. And this is something that we don't always think about, but I want us to, because it's so important. A lot of things happen, and I think sometimes we don't realize this, or we don't address it. Signs and symptoms of emotional shock include nausea, vomiting, and chest pain. So we need to understand that if a person has been involved with this, with something that's intense, something that's happened, they can go into emotional shock. Those are signs and symptoms that we can see. Usually not life-threatening, but can cause complications if the victim has other medical conditions. So if you are having actually a heart attack, or you're having a contusion to the heart, and then you start to have this emotional shock and having worsened chest pain, it's going to be hard to differentiate between, it's going to compound the issue is what it's going to do. And so we don't want that, or we need to understand that. So, and that it's not normally life-threatening, but it can happen. There are 5 stages that can occur: the impact, the heroic, I'm going to save everybody, the honeymoon, this is all good, disillusionment, and then reconstruction. Those are 5 stages to emotional shock. For my students, you do not need to know this, because they'll want to know. But for everybody else out there, you do. And then for my students, when you get out and practice in the real world, I'll want you to know this. So anyway, I hope this helps. It's a little brief overview of some shocks and some emergency stuff. And just please subscribe to my channel and give me a thumbs up. And I hope this helps. There will be some other videos coming soon, because I've got a lot of reviews to do for my own students and other things to talk about. See you soon.